Okay, guys, we're going to go ahead and get started. Hi, guys. I think it's lagging just a bit. I want to go over some of the ones that looked like there might have been some confusion. So, which finding in pancreatitis requires immediate action? Um, let's start with the right answer. So, rigid abdomen. Why do you think we might go with this? Why did you guys go with B? Whoever went with B. Oh, am I not? Oh my gosh, I forgot I can't see the chat. I forgot it's on. Hold on one second. Let me just pull up the chat on YouTube. So the rigid abdomen, it's a big red flag. So if the abdomen is rigid, that usually means we're dealing with peritonitis or internal bleeding. That's life-threatening. So this is the one that makes us kind of stop and say, "Eh, this patient's about to crash." On NCLEX and in real life, a rigid abdomen ass graph is never something you just monitor. You call that doctor right away because we're worried about hemorrhage, perforation, ass graph, right? Uh, jaundice. So jaundice is something we do expect in pancreatitis, especially if there's biliary obstruction. So the skin and the eyes turn yellow because bile can't flow normally. It's concerning, but it's not like a drop everything emergency concerning. It develops over time, so it's not like it requires our immediate attention or, we don't have to do something immediately. Uh, Nausea is expected. So pancreatitis patients almost always feel nauseous, sometimes even with vomiting. It's uncomfortable, yes, but not something that would make you call the doctor ASAP. You just manage that with antiemetics, supportive care. You're not panicking. And then pain, 8 out of 10. Pancreatitis is painful. So most patients will tell you their pain's pretty bad. While we absolutely want to treat pain, an 8 out of 10 is not the highest priority. Definitely not compared to a rigid abdomen. Makes sense? Pain is expected. A rigid abdomen isn't. Everyone got that? Okay, let's see. Okay. Interventions for myxedema coma. This is a SATA. Okay, so you guys wanted to go with airway support, it looks. Well, it looks like everyone went with pretty much just warm blankets. Let me read. Airway support, diuretics, warm blankets, levothyroxine. So first off, you want to remember myxedema coma is severe life-threatening hypothyroidism, right? So the body slows down to the point where metabolism, perfusion, oxygenation, they're all at risk. So these patients can die quickly without doing something aggressively. So when you see myxedema coma, you're thinking airway, you're thinking circulation, thyroid replacement. So let's go through them. IV levothyroxine, yes, these patients are in severe hypothyroid crisis. So the priority treatment is to replace the thyroid hormone immediately. We don't use oral because their gut is slowed down and the absorption is going to be poor. So IV is the fastest and it's the most reliable way to get that medication in. Warm blankets is also correct. Remember, hypothyroidism slows the metabolism, so patients get hypothermic. In mixed edema coma, they could be dangerously cold. So warming them is not just comfort care, it's literally saving their life, it's stabilizing their body. Um, and we're going to use passive rewarming like blankets, not aggressive warming devices, because aggressive warming can then cause vasodilation. That'll worsen hypotension. Not diuretics. That's not part of treatment. So the issue here is not fluid overload, but rather hypometabolism. So giving diuretics could actually worsen hypotension and perfusion. Airway support, yes, these patients can be so lethargic and weak that they lose their drive to breathe. So their respiratory muscles are slowed down and carbon dioxide builds up. So intubation or ventilatory support might be required as well. Okay, so which order is priority for DKA? Which order is priority for DKA? So do we think IV fluids is priority? So when we think about diabetic ketoacidosis, the body is in a state of severe hyperglycemia, dehydration, acidosis, electrolyte imbalance. The order of priority is really important here because if you do things out of sequence, you can make that patient worse. So insulin drip. So that feels tempting because insulin is what will actually fix the hyperglycemia and stop ketone production. But insulin should not be started first because if you push insulin before replacing fluids, you're going to worsen the patient's shock. Insulin drives potassium into the cells, and if you haven't stabilized their circulation first, that can crash them. So insulin's absolutely needed. It's just not first. And EKG is definitely useful in DKA because potassium, like I said, shifts in potassium can cause arrhythmias. But you want to think about NCLEX priority. So do we stabilize circulation or do we put stickers on a patient's chest? The EKG is important. It's just not first. It's not the first life-saving thing to do. And then electrolytes are extremely important, especially potassium, because insulin therapy can drop potassium quickly and lead to arrhythmias. But again, you don't go to correcting electrolytes until you fix the biggest threat first, which is the circulation collapse from dehydration. Now IV fluids, that's priority. Always fluids first. Patients in DKA are massively dehydrated from osmotic diuresis. They've been peeing out liters and liters of fluid. Their blood is thick like syrup. If you don't restore volume first, nothing else you do will matter, right? IV fluids are going to stabilize circulation. It's going to improve perfusion. It's going to prepare their body for insulin and electrolyte management. So in DKA, always think fluids first. Insulin will fix the sugar. Electrolytes will stabilize the heart, but if the tank is empty, nothing else you do will work. You have to fill the tank with IV fluids before anything else. Make sense? Okay, so which lab value in cirrhosis is priority? So cirrhosis patients have multiple abnormalities. So it's definitely important to know which one you're freaking out about. So albumin 2.5. So albumin is normally 3.5 to 5. Cirrhosis patients usually have low albumin because the liver can't make enough protein. So a level of 2.5 will cause ascites, edema, but that's chronic and that's expected in cirrhosis. We're not freaking out about it. Platelets 160. So normal is 150 to 400. 160 is still normal, not priority. INR 1.5. So the liver makes clotting factors. So cirrhosis patients usually have an elevated INR, but 1.5 is only slightly prolonged. I'm not freaking out about that. Just monitor it. Again, not a priority. Ammonia 150, that's priority. Normal is 15 to 45. So a level of 150 is way too high. That's going to signal to us hepatic encephalopathy. So that means toxins are backing up into the brain because the liver can't detoxify them. So that puts the patient at risk for altered mental status. Makes sense? So in cirrhosis, the body can't detoxify ammonia. So a high ammonia level doesn't just mean a bad lab, it means the brain is being poisoned. That's why ammonia is always the emergency in cirrhosis, and you'll treat it with lactulose to flush the ammonia out through the stool. Okay, let's see. Which finding is most concerning in digoxin therapy? So heart rate of 65. Now, we do check the heart rate before giving digoxin, and we usually hold it if the heart rate is below 60. 65 is borderline. I'm not freaking out about that. You would just still monitor, not a huge big red flag to me. Nausea. That is one of the earliest signs of digoxin toxicity. So it's definitely something to watch for. Um, but I would say like GI upset alone isn't as alarming as when it's something neuro or vision that's changing and showing up. Vision halos, that's a hallmark sign of digoxin toxicity. So if a patient says they're seeing yellow or green halos around lights, that's a major red flag. Basically, it means digoxin's reached those toxic levels. Fatigue, fatigue is fatigue is non-specific. A lot of patients with heart failure, um, are tired, so it doesn't necessarily mean toxicity. Digoxin's tricky because the early signs of toxicity kind of look like a stomach bug, like nausea, vomiting, abdominal pain. But once you see the halos, especially like I said, those yellow or green vision changes, that's a big red flag. And remember, digoxin toxicity kills through arrhythmias, not the GI symptoms. Awesome. Congratulations. So as always, if you won, please email contact at nclexhighyield.com. First, second, third, fourth, and fifth place, congratulations to you all. And again, please email us at contact@nclexhighyield.com to get your prizes. Okay, and we'll see you again at another trivia night. Thank you for participating, everyone. Have a good night. Bye, guys. See you all next week.